Our next speaker will be Rabi Chavi on brain science and extracerebral syndromes. Rabi Chavi is from Germany and he's a professor and director of the Center of Prenatal Diagnosis and Human Genetics in the Berlin. His special interest in fetal ultrasound, including fetal heart and 3D evaluation, first trimester ultrasound, and ultrasound in genetic disease. Welcome, sir.
Good afternoon, ladies and gentlemen. I'm grateful for the kind invitation to this first Fetal Brain World Congress in Ahmedabad in India. I'm going to give my talk online, and I hope that the message can be clear at the end, and if there are questions, you can ask me, of course, online. So my talk today is on the brain science and extracerebral syndromes, which is quite another approach than we discuss when we discuss on fetal neurosonography. I have no conflict of interest to declare in this talk. When you look at, for example, cardiac anomalies like detecting an AV septal defect, we have learned over the years that when you see this sign, it could be typically a hint of trisomy 21. It can be a typical hint of isomerism. It can be also a sign of other syndromic conditions, but it can be also an isolated findings, leading us to look for more information outside of the heart. So we have learned, for example, that fetal echocardiography can be used not only to discover cardiac anomalies, but also to analyze cardiac functions. In fetal infections, you can look at the heart, and other conditions can also fetal echocardiography provide also some important knowledge. And my message today is going to focus on the brain to show you that looking to the brain can give you some hints of some extracerebral anomalies. In other words, I want you, in similarity to the fetal echocardiography, to show you that the target examination of the brain is not only what we have learned in the last years to focus on the typical diseases of the brain, like for example, in this paper on the genetic basis of brain malformation, to look at some genetics of the brain, but can be used also to have a hint of extracerebral syndromes. Now, looking for these images here, you will know exactly what what I'm showing you. So you see these are all images of brain abnormalities where most of you will have an idea what's going on, but can also have an idea of other additional signs to look at in the brain and outside the brain. Let's start with some basic things like the one we know about cerebral size and numerical aberrations. And my messages is going to focus today on the role of the cavum septipellucidity in this concern. So looking at the CSP can lead you to detect on one hand the complete absence of the CSP in the context of holoprosencephaly. It can lead to the detection of an absence of cavum septipellucidity in Agenesis of corpus callosum, and also the detection of a dilated CSP, which can be a variant of the norm, but can also be found in some numerical aberrations. Let's start with the first one. When we look at trisomy 13, the typical hint is in the brain is the presence of holoprosencephaly, and additional signs are known as the facial anomalies like median cleft, polydactyly, and on the heart, and so typical facial abnormalities. And holoprosencephaly, as seen in this case, can be, as you know, allobar, semilobar, and lobar, but I'm going to skip this part because it's quite obvious. When you discover a holoprosencephaly, we know that it can be a hint of one of the common numerical aberrations, but can be found also in some deletions. It can be found in Smith-Lemli-Opitz syndrome and in other diseases like diabetes, alcohol, and it was also related to drugs. Ideally, what you should keep in mind that one of the main features is also related to some cholesterol metabolism, which is involved in some of these conditions as well. Look at now trisomy 18. Trisomy 18 was, let's say, known for years because of the first semester scan, but in the age of NIPT, you know, like me, that we have also patient having NIPT, which is positive for trisomy 18 as a false positive. And sometimes you may need to learn again and to seek again for additional findings, like the presence of an inlet VST on rocker bottom foot and abnormal hands of cleft palate, but also on brain findings. You see this, the mid-face hypoplasia can be a hint, but also the dilated cavum septi pellucidity. So what are the typical hints in the brain of trisomy 18? We have learned in the 90s, these were the choroid plexus cysts, but also the presence of a strawberry-shaped head. Anencephaly was also related to it as cerebral signs. But there are some additional signs known in the last years as open spine bifida and dilated fossa. But also I want today to introduce you to new interesting signs, the typical abnormality of the corpus callosum, but also the CSP and the posterior fossa with the cerebellum. So this is here a abnormal corpus callosum in the context of a trisomy 18, when you see the posterior aspect of the corpus callosum was not really developed. Now, the recent cerebral signs are the dilated cavum septi pellucidity on one hand, and also the cerebellum and its shape and size. So let's see now what is the wide CSP. These are this lower part, there are twins. One has a trisomy 18, the other one is normal. You will tell me, of course, I recognize this on the shape of the head, but the head shape is not always the strawberry-like. But what you see here is the quite difference in the size of the CSP, and this was observed and reported by the group from Tübingen, from Oliver Kagan and his troop, where they were able to discover that 90% of trisomy 18 had a dilated CSP. In my small series, not published, we had 60% of the cases have a dilated CSP in the context of trisomy 18. So people ask me sometimes, what do you do if you see a choroid plexus cyst in mid-trimester? I tell them I look at the CSP, because in the combination of an enlarged CSP, it can be a typical hint of the presence of trisomy 18. Not always, let's say, could be some mosaicism or some other feature, but this is so typical picture. You see here, this is another case. You see, it was discovered here at 23-week gestation, because people today think they see always early gestation the trisomy 18, but they may be also missed in the age even of nuclear translucency. Now, another sign here is the shape of the cerebellum. We were until now mainly focusing on the dilated posterior fossa, which is okay and interesting and important, but a group from Japan published some years ago an interesting observation. What they did is they measured the anterior posterior diameter of the cerebellar hemisphere and compared it to the transcerebral diameter. And they found out that the anterior posterior diameter is smaller, and this is why the relationship is shifted and be lower. So what they did is they measured the TCD, which is not so really significantly smaller, but looking to the anterior posterior diameter, it is always smaller in trisomy 18 fetuses, and putting the ratio of both, they found a set of ratio of 0.5 to 0.6, the ratio being around 0.4. So next time look at the brain like this one, keep in mind it can be a hint of trisomy 18 to have a smaller anterior posterior diameter, as reported by Takano and co-workers. Now, what about trisomy 21? We have learned over the years that the typical hints are the brachycephaly, ventriculomegaly. Remember, it is one of the checklists we do when we see ventriculomegaly to look at trisomy 21 features, but it can also be a dilated cavum septi pellucidity in 30% of the cases, as reported by Abele and co-workers, as you saw before. But also, it seems that the corpus callosum may be short, but this report by Tuchek and Sinkovskaya was not really, again, confirmed by other groups, but it maybe also play a role. I'm not sure in my experience if this was related only the size. In general, it has more abnormalities on the corpus callosum in trisomy 21 fetuses. However, what you should keep in mind is the role of the cortex and cortical atrophy, because you know that fetuses with trisomy 21, when they continue pregnancy, sometimes at term they have microcephaly, and microcephaly could be also due to a small brain, which is also can be associated with an enlarged pericerebral subarachnoid space or pericerebral space. In other words, this was a fetus. I saw trisomy 21 with an AV septal defect. I was surprised of the brain, and looking then transvaginally I saw a dilated pericerebral fluid. I saw abnormal gyration at 22 weeks, and you see the flat Sylvian fissure. So we may have abnormalities in the cortical development in trisomy 21 fetuses, and this is why I think it's worth to look at the brain transvaginally as in this case. And you see here these images are so typical of an abnormality, and no one will have directly expected to have a trisomy 21 in such fetus, but this was the typical picture of the brain. And looking in this picture to the corpus callosum, you see that it is abnormally thickened and short. Now, summarizing the CNS in aneuploidies, we know that there are some typical features, as in holoprosencephaly being found in trisomy 13, triploidy, and sometimes in trisomy 18. We find spinal bifida mainly in trisomy 18 and triploidy. Posterior fossa anomalies mainly found in trisomy 18 and triploidy, but also 13 and 21. Ventriculomegaly being a main feature of trisomy 21. Chorial plexus cyst of trisomy 18, but also others. And abnormal corpus callosum, mainly typical for trisomy 18, but the other one as well. And the dilated CSP, as added recently, can be found in all of these. Now let's move to the next group of the copy number variants. This is the CNVs. So typically for duplications and deletions. I think the most common one is what was called the Pas-Digeorge syndrome. Today it's called deletion 22q11 syndrome. As we know, it was called catch-22 because of the heart anomalies. But asking a pediatrician or pediatric neurologist, they will tell you yes, but the children, they have also abnormal brain along with the abnormal heart. So the typical cardiac anomalies reported are the interrupt aortic arc, but also conotruncal anomalies as the one put in this list. The presence of an right aortic arc or an ARSA increases the risk of 22q11. So you see here, these are the typical features of the abnormal heart, features like an interruption of the aortic arc, and all are associated in this case with the small thymus, even if the heart looked normal, as in this case. Now, there are in the literature data, postnatally mainly and in childhood, on the neurological abnormalities. Typically, there is the polymicrogyria with the deletion 22q11 syndrome, and in the old list of Barkovich, of the different signs of the MCDs, 22q11 as a typical feature of Sylvian fissure region, and this is something you should know. But for years, I have not really observed this in the fetus. But looking at some images at late gestation, we see that in the normal fetus, we have less gyration as in this case, and you see in comparison these high number of gyrations seen in this fetus as 30-week gestation, and these can be unspecific, but along with these other signs like dilated CSP and the cardiac anomalies may be a hint for 22q11. And there's another case here given to me by Dr. Quarello from France, where it showed the pericerebral space was dilated in the posterior aspect of the opercular region. Now, another observation was what we reported some years ago, was also dilated CSP in these fetuses, published in Prenatal Diagnosis some years ago. And we found out that after 22 weeks gestation, 90% of the fetuses had this dilated CSP. In other words, this can be an additional hint in fetuses with 22q11, especially when you have a cardiac abnormality, which is not typical for trisomy 18, but also suggesting the presence of abnormality. So in other words, what I want to point your view on, looking at the CSP, and you see here in these cases were all associated with 22q11, can be a hint for extracerebral syndrome. Because, if you go to a pediatrician and ask me, I saw the CSP enlarged, they don't know this sign because postnatally, almost all children have, when they have cavum septi, they may have closed and they have only a septum pellucidum. So if it's present, it may not be of hint to ask a pediatrician on this side because this is a typical feature of prenatal hints. In other words, this point which is the CSP, as you have seen, can be, of course, a normal variant since a dilated CSP is present according to the reference range in 5% of the cases, but can be a hint of, as I showed you, the common trisomies, 22q11, but can also hint, as we published before, on corpus callosum dysgenesis, which is in also or partial agenesis of the corpus callosum, which is also can be associated with extra cerebral anomalies as well. Now, another hint in the brain for the lesion duplication can be the small cerebellum, because a cerebellar hypoplasia or photocerebellar hypoplasia can be present here together with a cardiac anomaly in the Cri-du-Chat syndrome, which is a deletion 5p minus. So if you see a small cerebellum, don't shout first, oh, it could be PCH, pontocerebellar hypoplasia, and we seek for the 15 different gene anomalies. Look at the face. If there are some facial features, look at the heart, because you may be in the way of discovering this condition, which is a Cri-du-Chat syndrome, discovered mainly by looking with a fish or with the microarray. Looking to this paper published from the Chinese group, they examined the posterior fossa with microarray and found out that the typical deletions found in these cases were 30% of the cases, typically in association, as I told you before, with the Cri-du-Chat syndrome, with sex-P deletion and sex co-deletion and X chromosomal aberrations. In other words, keep in mind, if you see an abnormal posterior fossa, think on trisomy 18, think on the Cri-du-Chat syndrome, but also on deletions like 6p, 6q, and on XQ chromosome. There are more abnormalities associated with abnormal karyotype, especially with microarray, and you see for the CNS, we find 6% of the cases, but more if it's affecting the posterior fossa. So keep in mind with CNS anomalies, it can be the hint of having something else extracerebral as syndromic conditions. I will come at the end to discuss with you a few monogenic diseases. These are the ones not detected by chromosomal examination, not detected by microarray, but mainly by either a targeted panel for some genetic anomalies, or by doing today we do the trioexome as a routine procedure when we see something severe like this. So one of the features could be these echogenic foci here in the brain, and you see here how it looks like. You see 1, 2, 3, 4 features, and these are rarely seen by abdominal scan. They are better seen transvaginally, but this is the typical feature you will observe in the presence of tuberous sclerosis. These are cortical tumors. You see here the echogenicity, but you see also the abnormal gyration in the region where they are present, and you can imagine that after termination or after death, these were so hard on the brain, they were called tumor by Bournonville in France in the 1880s. You see here, these are the SEN, which is the typical lesions in the region of the foramen of Monro. Now, rhabdomyoma can be found in the presence of the heart, but if you have seen several cases, some of the rhabdomyomas may be not present, so the brain lesion alone is already a typical hint for the presence of TSC1 or TSC2 conditions. But in general, we find always a combination of heart and brain anomalies or brain suspicions in these cases. Now, another condition, which is the Char syndrome, is known by many of you as a cardiac abnormality, together with some facial features like the presence of coloboma, but can be also microphthalmia, unilateral, bilateral. It can be associated with atresia of the Kuani, quite rare, but typically features like facial clefts, but also some brain findings. Typically, there are two typical brain findings associated with the Char syndrome. These are the arenaencephaly on one hand, but also an abnormality is the posterior fossa. So what you see here is a paper published by a French group where they analyzed the typical features in the MR findings in 26 cases with the prenatal diagnosed Char syndrome, and they found typically the features of arenaencephaly, and on the cerebellar side, it could be cerebellar hypoplasia or Verme hypoplasia or Blake's pouch cyst. So this is why it's quite difficult to see them as diagnostic, but it can be also hint. But for arenaencephaly, which is more better seen later in gestation after 28 to 30 week gestation, you see that there are the absence of the sulcus olfactorius as seen in these cases. These are 3 fetuses showing they had Char syndrome, but looking to this posterior fossa, you may see, oh, I see light dilation here. In the 4th ventricle, I see dilation of the cisterna, or I have an image of could be a clefting. What I want to point your eye on is don't focus mainly on the cerebellum. Consider this as a hint and look for more. If you see more, especially at the level of the heart or the ear or the face, think also of Char syndrome. So in other words, from this talk, I hope you will put in the posterior fossa not only the typical genetic disease of the brain, but also add Cri-du-Chat syndrome and Char syndrome to your checklist. For the sulcus olfactorius, if you look at the basal aspect of the brain, you will find here the 2 olfactory bulbs, and they are in this sulcus olfactorius. That means that when they develop, the sulcus can be the hint for us to seek for. But as you know, the brain sulci and gyra develop later in the 3rd trimester. This is why the sign cannot be seen. If you see early GSA, so if you look at now the sagittal view, you see the corpus callosum is present here. So in the region where we are seeking for the sulcus olfactorius may be anterior to the corpus callosum. So in the frontal view, where you don't see the genu of the corpus callosum or any CSP. And this paper was one of the first on this field, also from France. They analyzed on MR of children of 10 patients with Char syndrome. They found none of these had an olfactory sulcus, and the bulbi we cannot see prenatally yet, but the OS is olfactory sulcus, and you see here this is absent, and here it looks like arelencephaly you see in the region where it's anterior to the CSP and to the genu. So the absent sulcus olfactorius was also put in the second part of the neurosonography as a hint. And you see here that according to the gyration, it's more a late sign. It can be absent in 3 conditions. To my knowledge, it's Char syndrome. It is trisomy 13, which is also associated with arelencephaly, and one typical condition associated with an absence of the smelling nerves of the sulcus olfactory is the Kallmann syndrome. So you see here, this is a normal view in a transabdominal view of the 29 weeks gestation. You see these 2 indentations, and you see how by moving from the region of the cavum septipallidus more anteriorly, we start seeing the 2 sulcus olfactorii. And in this fetus here, having cardiac abnormality, having normal microarray, looking to this brain at 28-week gestation, let us miss these sulcus olfactorii, and then we decided at that time to do selectively the Char syndrome panel or genetic checking, and which was confirmed. Today, probably we'll do, when we see a cardiac anomaly, in the meantime, we'll run almost always just after the karyotype, the trio-exome and discovering this condition. But again, another hint on the brain of extracerebral malformation. Another disease which is quite easy for many of us, because you see the bones are short in early gestation already, is thanatophoric dysplasia. But I want to show you that if you are expert on the brain after such a big meeting today, you will be learning how to look at the brain when you suspect skeletal anomalies. And this is not the sign I want to show you, is related to the FGFR mutation, and it can be also detected in 1st semester. So what is thanatophoric dysplasia type 1? We have the typical short bones, we have the boned bones, we have the typical short hands, and we have the short ribs as a sign of a thoracic hypoplasia, which is also leading to death, as the name thanatophoric says, with the frontal bossing. The frontal bossing can be found in many other diseases, but the typical finding in the brain in these fetuses is the presence of a temporal lobe dysplasia, which is here the abnormal gyration. You see at 22 weeks, high gyration, a lot of gyra present, which is very unusual, and this was observed by 2 authors, by Wang from Canada and by Blas from Trondheim, in the fetus antenatally. And the same can be shown in these fetuses. You see here one at 16 weeks and the other one at 22 weeks. Now, knowing that there is something on the bones and knowing you could suspect thanatophoric dysplasia, please next time look at the brain. take the plane of the lateral ventricles and go a little bit lower to see the temporal lobe, which is a little bit under the level where you see the lateral ventricles. You see at the between the lateral ventricles and the brain, you discover or you recognize the cerebellum, and you see a lot of gyri present. And I promise you, you can see it at 14 weeks and 13 weeks as well. Interestingly, it's not only about thanatophoric dysplasia, but it's also related to FGFR mutation. So in other words, also present in some fetuses with Apert syndrome because they have also an FGFR mutation. And you see the typical findings are the frontal bossing, the turicephaly, but also the mitten hands in these fetuses. So people will tell me, I don't need this brain sign to look at it, but sometimes is the abnormal, let's say, shape of the head in the context of craniosynostosis, not obvious at 22 weeks, but become more evident. And this is why in this fetus, there was an abnormal shadowing and suggesting craniosynostosis, but the growth was normal. And looking to the brain, I discovered these abnormal temporal lobe development and assumed, well, I know this sign from the from thanatophoric dysplasia, but it does lead to thanatophoric dysplasia. But I remember that I read a paper on the presence of this condition also in Apert syndrome. And then I looked more carefully to the hands, because the first time I had a look to the summary, I said, okay, who needs for Apert syndrome to look at the temporal lobe, because we see them on the hands. But if you don't have this picture of a craniosynostosis primarily seen, it's not obvious. You see the shape of the head here in these cases was normal first at 22 weeks, but then later on it became more obvious. And you see here, this is a 27-week gestation where the diagnosis was confirmed, what can be found. So in other words, I showed you some monogenic diseases like CHAR syndrome, like tuberous sclerosis, and like FGFR mutation associated with the brain findings we know, but we did not discuss before, obviously, in many of the topics. I come to the end. I skipped, due to the time, the Joubert syndrome sign of the typical hint of what is called of the Muller-Tooth sign of Joubert. And I want to summarize that my message is to show me your brain and I tell you what syndrome the fetus may have. I show you typical images of trisomy 13, which can be holoprosencephaly or arenecephaly in gestation. Trisomy 18, not only the chorionic exocyst, but also keep in mind the dilated CSP and the short or small anterior posterior diameter of the cerebellar hemisphere. Trisomy 21, keep in mind also not only ventriculomegaly, but also could be a microcephaly with an abnormal gyration of the cerebellum. 22q11 with the pericerebral fissure, but also dilated CSP in 90% of the cases, and the Cri-du-Chat syndrome, typically with a small cerebellar diameter with a normal shape of the cerebellum. Tuberous sclerosis with a nodular heterotopia plus the typical tubers as echogenic dots in the cerebellum. Thanatophoric dysplasia and Apert syndrome with these gyration, abnormal temporal lobe dysplasia, and CHAR syndrome with the abnormal posterior fossa, not specific, but mainly with the presence of these of the sulcus olfactorius. I did not add to the CHAR syndrome the abnormal cochlea and abnormal, let's say, how to say, the semicircular canal, because I still think it's quite difficult as a challenge, but one day you will get all this information as well on your own. And this is why I thank you very much for your attention. I showed these images from my talk, and I hope you got new approach to the brain and not focusing only on the typical genetics of the brain, but looking at the brain as a hint to seek for more other extracerebral findings and syndromic conditions. Thank you very much.
Thank you, sir, for the talk. For the next talk, which is on the syndromic brain, I would like to invite none other than Dr. Gustavo Malinger, who is the course director of the current Fetal Brain Congress, along with 6 other directors. He's a pioneer in fetal brain imaging, and current guidelines are developed by him. He has more than 180 publications and book chapters, which includes first description of normal development of corpus callosum and cerebellar vermis. He is currently senior consultant at LISP Maternity Hospital, where he served as the director of OBGYN ultrasound division and continues to do his private practice. Please, sir. Thank you, sir.
Hello. Okay, before I start, I want to give you, first of all, to say thank you to Prashant and to the organizing committee, the Prashant family, and all the organizing committee. And we are going to have a formal introduction and welcome lecture tomorrow. Some messages. First, not related to my lecture. First of all, be aware of meta-analysis and reviews of the literature, particularly when speaking about the brain, because you can obtain very weird results when you do a meta-analysis. If you should go, when you read a meta-analysis, you go to the cases and see to the papers and see how different they are and how different the quality of the examination is. So be careful with meta-analysis. The second issue regarding the early diagnosis of posterior fossa anomalies, from my experience. If you perform an ultrasound early in pregnancy, and I perform in Israel during the second trimester at 14 to 16 weeks, and you say that something is wrong with the posterior fossa, and the chances that you are wrong if there is no any other malformation, because if the fetus have 4 hands, 3 noses, and 6 eyes, it's clear that the posterior fossa can be abnormal, okay? But it uses only a posterior fossa anomaly, okay? And you make a diagnosis and you perform an interruption of pregnancy because of this, the chances that you are killing in 100 fetuses 99 healthy ones are big. And this is our personal experience. So always follow the cases when you have isolated. And perhaps it's the same with corpus callosum or with mild ventriculomegaly. Take a deep breath, wait a little bit until the patient come back in 2, 3, or 4 weeks, and we are going to see it. The problem is that in many countries, you need to perform termination of pregnancy before 21 weeks in Japan or 24 weeks in some states of the United States. But I think that one of the powers of neurosonography is not to diagnose pathologies, but one of the powers of fetal neurosonography is to avoid to perform unnecessary terminations. Okay, now to my lecture. Giving a lecture after Ravi Chawi is very difficult because he's one of the best speakers we have in our field, and I should tell him thank you very much, because I am here probably because in part because of his help. He introduced me to ISWOG at the times that ISWOG was a good society. It's not what it used to be today, but when Ravi was there and Dario was there and Jean-Luigi Piro was there, was a very nice and very important society. Now to the lecture. I am going to speak about syndromes where you see something in the brain and you look for other signs. Now, it's important to recognize that there are different types of problems of morphogenesis, and we speak about malformation or malformation sequences, but there are other anomalies of morphogenesis, that is deformation or deformation sequences. There are the disruption or disruption sequences, and also you have the dysplasias or dysplasia sequences, and there are the etiology and the cause of this is completely different. Now, if you want to get introduced to the diagnosis of human malformation, I recommend this book by the first author years ago was Smith, Recognizable Patterns of Human Malformation. And if you look there, which syndromes they can have something related to the brain, these are some of them. You may have problems related to overgrowth. You have all the craniosynostosis syndromes, and there is a list of unusual brains with neuromuscular findings and associated effects. And you see that the list is quite long, and many of them you hear this name of these syndromes through the lectures today, and it will follow tomorrow. Now, another thing that is important in this book that you can look and say, okay, let's see the syndromes that have agenesis corpus callosum. So you have the list, and you see also Dandy Walker, also macrocephaly, microcephaly. So you have a suspicion. You should look at this book and search what else. It can be done also by OMIM. So what is the imaging approach of fetal dysmorphology? We are obstetricians, and most of us are obstetricians, not all of us, but most of us are obstetricians. And as our specialty residency and specialty, we are not, most of us, we are not completely dedicated to neurosonography or to the brain. So every time that you think that you see something, you should remember there are other people that understand more than you, and you need to learn from them. And one of the things that is important to learn is when you took an anamnesis, it should be complete. Okay, it's not only to say yes, 3 children, both of normal, or the parents are normal, because you know there are a lot of parents that are completely normal but they have a syndrome. And today, every patient to come to us, let's say with an agenesis or a pathology of the corpus callosum, before we start, we ask the patient, the father and the mother, to do something that is very simple. I say, put your hands like that and move it. Move one, okay, and you see that the other one is not moving. Move the other one, and this is not moving. But the patients that have a very particular disease, that is deletion in the colorectal cancer, DCC is not deletion in the corpus callosum, but is deleted in colorectal cancer. Okay, when you ask them to move this one, they will move the other one. This is called mirror sign. And actually, if you look at the father that has this sign, you will see that also his corpus callosum is abnormal. And if you ask if there is someone in his family that have colorectal carcinoma, most probably you will hear that they have a very long history of colorectal carcinoma. So anamnesis is very, very important, and anamnesis in deep. If you don't have time, ask for your pediatric neurologist or for your genetician to take a good anamnesis, because we forget how to take it. Past pregnancies history, a review of previous ultrasound examination if performed, and always the first question I have when there is a patient that comes for a second opinion is who performed the ultrasound? Who make the diagnosis? Because you know, you work in a small country or you work in a city or big city, you know which ones are the ones that understand and which one are the ones that don't understand. So this is also important. A full examination. This is something a patient comes to you because there is agenesis corpus callosum, and you look at the brain and you look at the brain and you forget to look at the fetus. So what I propose is a patient come to you for a second opinion, or you see something wrong in the brain, leave the brain to the end and start looking at the fetus, perform a complete second or third trimester examination that you know not always is easy, but at least you should try to do, because when you focus in the anomaly A, you have very good chances to meet B and C and D. You prepare a list of suspected findings, one after the other. Not necessarily will be correct, but your impression. Now, if the diagnosis is not straightforward, you should search the literature, go to the literature, tell the patient, I want to have a consultation, I want to look at the literature. It's not a bad thing to tell the patient that there is something that you don't know. Now, currently, if you think that there's an anomaly involving the brain or a syndromic anomaly, the first tier, you should go straight today. If it's possible from the economic point of view, if the patient is willing to do that, you should go straight to do exomic sequencing, because you will, the brain, this is the place where you are going to find the answers that you cannot reach by imaging. And extremely important, have a multidisciplinary consultation, because as I told you, we are obstetricians and we don't understand everything. Now, I'm going to tell you a small history I always tell in my conference. You know, when in the morning meeting in the department, the residents were there. We arrived to the morning, and the whole department is there. So the resident will say one day, today the ultrasound missed the ectopic pregnancy. Okay, it's not bad. After a few days, he will come back. The same resident that will say, today I diagnose an ectopic pregnancy. Okay, so when you speak about ultrasound or MRI, there is not such a thing that ultrasound show, you show. And as human beings, we are different, our capacities are different, our experience is different. So, but always are you that make the diagnosis and the interpretation, not the ultrasound and not the MRI, because the MRI and the ultrasound never participate and go out from the morning meeting. Now, this lecture will be one that is teaching by examples, as the surgeon says, see one, diagnose one, and teach one. This is the diagnosis. You have a case with severe ventriculomegaly, and it's a male, okay? Everyone will say, okay, we have seen cases here, one after the other. What you need to look for, you have severe ventriculomegaly, early severe ventriculomegaly in a male, okay? You go and you look at the hand to see if there is a adducted thumb. You have reached the diagnosis, everybody say, well, bravo, go ahead. But sometimes there is more difficult, because you don't have ventriculomegaly and it's a male. Okay? It can be exactly the same. There is no ventriculomegaly, there is a genesis of the corpus callosum. Everything seems fine, but you see a small corpus callosum at 21 weeks, and you see the still present CVI, cavum velum interpositum, that can be normal, but is many times will be accompanied by a short corpus callosum, because it's the corpus callosum that is pushing back the cavum velum interpositum. So if there is there, and the corpus callosum is small, you need to think, and this is a difficult one, but again, you go to the fetus, you look at the fetus, and you will find exactly the same, the adducted thumb, and this is, these two cases are cases of L1 CAM. So, this is from Nina's lecture. You have the fetal X-linked hydrocephalus. It's a male. You have aqueductal stenosis. You need to have ventriculomegaly and the adducted thumbs. So you know you are quite sure that you are in the correct diagnosis. But also you may have ventriculomegaly plus callosal anomalies, and also you may have callosal anomalies without ventriculomegaly and can be L1 CAM. But it's not so simple. Okay, this is the images. L1 CAM have other disorders. Okay, it's not only hydrocephalus adducted thumb in a male. You may have partial or complete agenesis of the corpus callosum. You may have cerebellar Vermeer hypoplasia, hypoplastic pyramidal tract that are only diagnosed or by MRI or postmortem. But there are other findings that can be seen, and this is the study of nine cases published recently, where these fetuses may also have the encephalic mesencephalic anomalies, abnormal cortical development, callosal dysgenesis. There are two main phenotypes that differ mainly by the presence of the encephalic mesencephalic jointing dysplasia. Now look at this case. Okay, you have a case of mild ventriculomegaly. The corpus callosum is quite thin and a little bit short. The cerebellum is normal. There is irregular ventricular walls and also dysgyria. The gyri should not be seen like that. This we call dysgyria because we don't know how to call them. But this is a 30-week female. So it's not X-linked. So what else can be? This is the MR of the same patient 2 weeks later. You see the findings. What else can be? You start thinking, okay, let's go for exome, let's go. But again, you should ask for the anamnesis. And these are two sisters that both of them by themselves are L1 CAM, okay? And they have interruption of pregnancy in males, but now you have this case of prenatal ultrasound, the one that I show you, that has ventriculomegaly, the dilatation of the lateral ventricle, a thin and short corpus callosum, and she delivered, and the girl is today 12 years old with mild neurodevelopmental problems and attention deficit. And the daughter of the sister has another girl that has prenatal ultrasound with ventriculomegaly. The lateral ventricles were mild male ventriculomegaly. And again, she's 12 years old. We saw both of them at the same time. They have mild neurodevelopment and IDH. And also the two sisters have exactly the same, have mild neurodevelopmental problems. You see, everything is okay with you. Yes. Do you went to school? Yes, everything is okay, but both of them are carriers. So, and we publish this paper. It's about to be published. So it's a multi-center study. Many of the participants are here. And in the 41 fetuses, most of them were male, but we have 5 females with the AL1CAM syndrome. So remember, adductor thumbs, callosal dygenesis, aqueductal stenosis and hydrocephalus, DMGD, midbrain, hindbrain dysplasia, malformation of cortical development, most of them boys, some of them women. Now, there are some syndromes that can be diagnosed sometimes and other times not. And this is a girl that we saw years ago, and you see that the head circumference was growing very fast, okay? And we suspected that she presented with some kind of anomaly. You can see the frontal bossing, and here you see after she was delivered, her big head. We counseled to consider termination of pregnancy, although we were not aware of the disease. Okay, but the postnatal diagnosis was macrocephaly capillary malformation syndrome, and at the age of 12 years, she's extremely macrocephaly. When she entered the room, everyone see her because her big head. She didn't need the surgery, but she have attention deficit and hyperactivity. And this is something that ADHD, something that today is very common. In every family, you have one of them. And in my case, also I have microcephaly, attention deficit, particular hyperactivity disorder, and I am here lecturing to you. But this is the second case that we saw. Again, it was mild ventriculomegaly, macrocephaly, a very big and pronounced corpus callosum. From the MR, you start seeing that there is too many sulci, and you have polydactyly or syndactyly polydactyly. Okay, and this is the prenatal, the fetal MRI seeing the polymicrogyria that was confirmed after delivery. And this is the child, and you see here the huge hemangioma, and here you see the polysyndactyly in one of the legs. Now another case. This is a 32 years old woman, gravida 2 para 1, normal examination at 15 weeks. At 23 weeks, we have ventriculomegaly. The vermis was apparently not present, dysgenesis of the corpus callosum, and she was referred for termination of pregnancy due to severe brain anomalies. But this is the ultrasound at 23 weeks, and it's very clear that this brain is very bad. Okay, look, here you have more images showing the dysgyria, malformation of cortical development. The corpus callosum was poorly seen, ventriculomegaly, and something that is very common. We used to speak about polymicrogyria as a disease, heterotopia as another disease. But in these severe cases that are diagnosed fetally, the whole parenchyma is involved, and you see the abnormal sulcation, but you also see that the walls of the ventricles are very irregular, meaning that it's probably heterotopia. I think that most of you say this is very bad. Okay, so you have macrocephaly, you have 7 fingers, and you have hallus, double hallus, or two toes here. So we put together the diagnosis macrocephaly. Now we are clever. We have seen other cases: ventriculomegaly, including the third ventricle, vermen hypoplasia, suspected heterotopia, abnormal sulcation, polydactyly, plus bifid or broad thumb, and we have some possibilities, but actually it turns out with time that there is the same. At this time, we can be megalencephaly, polymicrogyria, polydactyly hydrocephalus syndrome, but it can be also megalencephaly capillary malformation syndrome. in time, it turns out that both conditions have the same genetic origin. So sometimes we need time and genetics to make the diagnosis, because you follow the patient, everything is apparently normal at 22 weeks, and the patient is referred for third trimester examination at 31 week because of the presence of a very big head. When I measured, it was 2.7 standard deviation. Okay, so a very big head. Since the femur was a little bit smaller than expected, I think in the possibility of achondroplasia. So I measured the angle of the femur, and it turns to be a quite wide. I said, okay, this is most probably a case of achondroplasia. But look, there was an extremely big, large corpus callosum at 31 weeks. At 31 weeks, the corpus callosum should be 32, 36, not 59. And you see a lot of the frontal subcutaneous was enlarged, big head. But if I put the measurement that was done at 22 weeks, it was normal, and it started growing. It started growing fast only during the third trimester. And here we were able to see again the increased amount of sulci. And in these cases, you can refer for MRI, but what is important, as I told you, to do an exome, and this is the fetus with the huge macrocephaly. This is the post-mortem ultrasound showing the big large corpus callosum. And look here at the sulcation, and I can tell you now, yes, this is abnormal sulcation in the temporal lobe. But this, you need to understand that this is nothing. This is related to the post-mortem changes. But the exome was the PIK3CA mutation. Today is very well known. Everyone is speaking about the PA1 AKT MTOR variants in focal brain malformations, and there are a lot of different changes there that can produce this macrocephaly, and which is very important. And Ritsuko demonstrate that, and also French group demonstrate that you may have a completely normal exome in the amniocentesis, because you have a somatic mutation. So the skin is normal or not, but can be normal. And the only way to make the diagnosis is afterwards to do a brain biopsy of different places and to look there for the mutation, because it can be somatic mutation. Another case, 29 years old, gravida 3/2, healthy, no familial history, normal nuchal translucency. The triple test was 1 in 230. The HCG was elevated. The first and second trimester ultrasound were considered normal. Alpha fetoprotein and the amniocentesis was normal, but the HCG was high. The CMA was normal, and we saw the patients only at 34 weeks because mild ventriculomegaly, and the patient come to us after someone else ordered to an exome. You know that if you have this, if you do a CMA today, the laboratories they keep the DNA, so you can ask later on to do an exome, and this is good. And you see here again, the head was was large, but it was within normal limits. You should remember that here we are using Hadlock curves, and Hadlock curves tend to have a very shallow range of normality. So the chances that if you use Hadlock to measure the fetus, and you think that is micro or macrocephalic, most of the cases are false positive. And very interesting, we use today the Chervenak curves that were done years ago without using the circumference, but only the spheric measurements. But they are the one that work, and they work because the range of standard deviation is quite big. There's not related to the discussion. When you measure the CRL, crown ramp length, you know when these curves were performed. This paper was published of the CRL, the Robinson curve. in the 70s. Robinson, they work with Ian Donald, and it was one of the first studies that they did, and it's in the 70s, and still we use them with the same with Tadlock. Okay, let's go. But when I look at the shape of the head was brachycephalic, we suspected that we have here a metopic rhinosynostosis. There was mild ventriculomegaly. The corpus callosum was apparently normal, a little bit strange, but was apparently normal. But when we look, it's a lot of fluid between the interhemispheric fissures. You can see here the suspected polymicrogyria. Okay, also here. And when we look in the parasagittal plane, there was a lot of fluid anteriorly. You can see a lot of fluid in fetuses in the occipital portion of the brain because the occipital horn is like a conus. So you can see a lot of fluid there. But if you see a lot of fluid in the ventral to the hemisphere, this is very suspicious that there is or brain atrophy, or this is related to macrocephaly. But another very finding that should be seen with respect is when you have a fetus that have something in the brain and have polydramnios, because the chances here that the fetus has something very abnormal are more than 50%. And when we look at the eyes, again, there was something strange here regarding the retina. We didn't like the shape of the lens. So we took images of the other portions of the brain, and we were impressed by the shape of these phalanx that were much shorter than this one. There was also micrognathia. Okay, micrognathia alone is nothing because you see, I have a little micrognathia. My wife says that I am not okay. And here we suspected that the vertebrae were too flat in relationship to the intervertebral space, and this something that's called platyspondyly. But of one of these things we were sure. Okay, we say okay, probably. So today what we do, okay, before we send to exome, we do what's called the HPO, Human Phenotype Ontology. There is a list where you put this is a program. You put ventriculomegaly, short corpus callosum, and it gives this sign and a number. Okay, so for the genetician, this is very important because if you perform an exome and you don't give the genetician any hint, he will find 19,000 variations and mutations and changes. Okay, but if you give them these HPO signs, he will put it inside, and the most probably causes of variants will go up. They will be in red in their program. Okay, so they will say, okay, this is most probably this or that. And the exome sequencing come with something that's called heterozygous mutation, the NFIX gene. Never hear about. When you look what is the NFIX gene, it's something that's called Marshall-Smith syndrome. There is someone here that knows what is the Marshall-Smith syndrome. Now you know. But before that, I have never seen a case. And when you look at what you can see that usually have ballet-shaped middle phalanx, short, narrow terminal phalanx, and other things. But the phalanx were the one that help to reach the diagnosis and to look for the gene and to be sure that this gene, this variant, is the one that is pathogenic. Some cases, and we present today one of these cases, that it's impossible to make a diagnosis because you see today this is a paper we published in conjunction with others, and you see these images, and you see that something is weird with the cerebellum. The shape of the cerebellum is asymmetric. all of these were different cases. And I personally have two cases, one very close to the other with this finding, and this is patient 1, patient 2. Okay, and the MR show the same finding because I learned that from Daniela. T2 MRI and ultrasound show more or less the same, some structural defect. If you want to have, again, with MRI, you need to use other sequences that can give things that ultrasound don't show. So the image, the morphology, if you put your transducer in the same place that the MRI, you will see more or less the same finding. And this is patient 2. And when they were born with huge hemangiomas. Now, this is what's called the face or faces syndrome that have posterior fossa anomalies, hemangioma, arterial anomalies, cardiac anomalies, sometimes you have cataracts and abnormalities of the sternum. And there were papers, and Laurent is here. They describe it years ago before we describe this. It was in a series of cases of cerebellar hypoplasia. Regarding cerebellar hypoplasia, for years I show a case. It was my 4th case that I diagnosed by transvaginal ultrasound. And years I went from one conference to the other showing a case of Dandy-Walker malformation in a fetus and I say, this is Dandy-Walker malformation. Everyone say, bravo, nice to you. But it took me years because I am dumb to understand that in trisomy 18, that this patient has trisomy 18, you don't have Dandy-Walker malformation. What you have is cerebellar hypoplasia, and it's described as was presented a few minutes ago by Ravi. So they published a series of 26 cases of cerebellar hypoplasia, and one of them had the same syndrome, the face syndrome. And there were other cases with prenatal and postnatal MRI that were diagnosed, and the children in these cases did well. So we put together a collaboration between the group of Laurent and a group from Germany, and we put together 8 cases. And Zvika Leibo, which is one of my colleagues, called it the cerebellar tilted telephone receiver view. Recently, it was shown that there can be also face without this sign. And I want to show you how something that appears bad can be good. And this is one of the girls, the patient 2, at 2 weeks of pregnancy, 6 weeks of pregnancy when she's treating with propranolol. This is at 5 weeks of pregnancy. The family traveled to Canada, and a few days ago, I received this image of the girl with the face syndrome, that she's completely normal, clever, and have not problem. The problem sometimes is when the eye is involved, when there are cardiac malformation. But by now, the prognosis in all the cases that have been diagnosed prenatally is quite good. And why I say that it's impossible to diagnose this in pregnancy, because there's a group that make the definition of the syndrome in children. And to have this syndrome, you need to have an hemangioma. And in utero, rarely you will see the hemangioma, so we cannot make the diagnosis. So I went through to those that are quite easy to diagnose, those that are sometimes you can diagnose, to those that are impossible to diagnose, but you can suspect. And I can tell you that I will not be here without the collaboration of very big group of physicians. And it's interesting because today in our department, there are three generations of physicians. Those that we have the old guy groups, you know, the asylum of all guys with Professor Iafo that is here. Now we were joined by Catherine Garel, myself, and another few that retired, but we continue to work. And we have the new generation led by Nina Kreiden, and we have younger fellows from all around the world with us. So when you see the boss or the ex-boss, you need to know that there is a very big group of people working with you, and I can tell not only you, but also them, thank you very much.
Thank you, sir, for this brilliant talk. Next, we have Dr. Prashant Acharya, who needs no introduction, but will still try give one. He is the Director and Chief Consultant of Paras Advanced Center for Fetal Medicine. He has special interest in fetal cardiology, fetal pathology and autopsy, fetal therapy and intervention, fetal neurology, fetal autopsy, and passion for teaching. He's founder of Scan Academy, co-founder of Fetal Brain Society, and author of 100 Thumb Rules, along with founder trustee of INSWA. He will be talking on role of 3D, 4D in fetal brain assessment.
So till the time they use their connectors to start the PPT, PowerPoint presentation. Again, let me thank you all very much. So you are here. So again, from the entire all the course directors, you all are here. So I feel very privileged and honored to be here and organizing the course on behalf of the entire course, all the course directors and all international fraternity and our all national faculties, those who are brilliant one. And I can guarantee you till now, till date, there is no fetal brain event specifically for 4 days, which has happened ever. And this is all because of a SID, which was, I think we are going to discuss it tomorrow rather than why should I discuss it today, rather than focusing on my talk. So 3D on fetal CNS, everyone knows that I'm a little bit more crazy fan about doing 3D and using the 3D, correlating it with the fetal autopsy specimen, and that's what we are going to do it. No hidden facts, nothing to disclose. So thank you very much again to all of you, so that what we are going to discuss. This is the dictum which I always follow. If you do what you did always, you are going to get always what you got. To get something which you never had, you must do something which you never did. So 2D imaging, everyone every day is doing, you are doing since years and years together, and still you are going to continue that. So you are going to get the same results. You may probably add little malformations a little bit earlier, but to have more passion, to create a passion in you, I think 3D will help you in giving not only the better images, but you will be able to audit yourself if you have missed some malformation later on after the birth or later on in the life. And I feel when it is Aladdin's magic lamp, if you use TV transvaginal probe 6-12 probe, I'm not saying 5-9, 6-12 probe with a 3D 4D neurosonogram, TUI multiplanar imaging and the render imaging, that's a master key to do something which you never did, and you should start doing it. It will give you, it has got a little learning curve, but once you have reached, you are going to get something which is very brilliant imaging. To do and learn or to do a neurosonogram, you need to do this. You need to squeeze your brain to maximum extent. Then you will be probably 50% of what we are. I would put it as all faculties, those who are sitting here, maybe Dario, maybe Gustavo. You will reach that mark, I can guarantee you. So 50% to reach, you have to do that squeezing of your entire brain to that. So a fetal brain, you need to understand the fetal anatomy, and understanding the fetal anatomy, I think today morning we have a whole loads of section and all sorts of fetal anatomy and pathology. Unless you understand the anatomy, you can never perform a volume image. Here you will have a 3D perception of the entire organ. And in 2D, you are cutting a slice. If you have, because the brain and the heart, these two structures are a 3-dimensional structure. And that is the reason I recommend to do a volume image, and that will give you quite a lot of information, because you can cut wherever you want. If you have got a one volume, you can cut sagittal, oblique, horizontal, axial, whichever way you want to cut, you can cut, and you will be able to evaluate that fetal brain. So a volume will be probably closest to reproduce the fetal brain anatomy, and that is what that's the reason I am really after doing this. As far as 3D of brain is concerned, during the first trimester of the fetal brain, or in general, the fetal brain changes at every 12 week. It is different. 15 it is different. 17 week it is completely different, and at 25 week it is completely different. because it's a different anatomy at every different gestation, you need really to understand. I'm here showing the power of ultrasound is equivalent to probably the MRI before 24 weeks, or probably a little more on ultrasound side. Because just look at on the top line, you have got a fetal autopsy specimen, and the last line you have MRI images with a high resolution 3 Tesla specifically done only for the fetal brain, and or even more the 3 Tesla. These are all experimental, so will be much more. And in the middle, it's in volume images, 3D volume images. So you will have exactly the same reproducible images during your 3D imaging, and that's the reason I feel if you learn 3D volume, it is going to be brilliant. An example: 21 mmCRL, 8 week of the fetus. Apply silhouette. You have got these kind of images. Zoom to the head, and then simply take axial sections, and you will have these images. So an axial section, you know that, okay, you have got the topmost is the third ventricle here, which is going to be the highest at the highest point during 8-week gestation. Here at an axial section, now you got, okay, lateral ventricles are formed. So you have ruled out practically holoprosencephaly. Today morning, Rutsika, who has shown you the holoprosencephaly at 8-week gestation or 9-week, is exactly what you can reproduce there. Okay, this is normal. Go back, you have got an aqueduct, this is a foramen of Monro, and then the rhomencephalon. Now, the shape of rhomencephalon, which is if I take it just like on the other side, you have a classical, why we call it as rhomencephalon, because the shape is like rhomencephal. So that is these are the things which you are going to get it. But look at the development of the brain completely from 7-week to 8-week, 11-week, and 12-week. Look at the posterior fossa, how the lateral ventricles are developed. This is the one where you have got a just beginning of two hemispheres which are forming, third ventricle and the rhomencephalon. Just look at this shifting of the brain, posterior fossa going more posteriorly. From the top it goes posterior, and the cerebral hemisphere enlarges, and this is what it tells you the complete story of the development. A nuchal section, you all are well versed, and that's where I will take a volume, and that will help me in giving all first trimester axial images, the fetal, the best of the best. Take one volume in a nuchal section. Anyway, you are going to evaluate nuchal. Add simple volume, 7.5 seconds, 20 degree, grab a volume, and then put it simple 1 TUI image. And this TUI image, you have got all sections, 9, take a multiplied by 9. And here, if you see the calvarium, which is good, Fox is intact. You see this white dot, this black dot. Actually, many people say it is third ventricle. Actually, it is not third ventricle. Okay, it is CVI, and the third ventricle is way below here in between the thalamus. But you can see the choroid bar, which is classically seen, the choroid bar, which Dario has today morning he has shown you. Look at the shape of the thalamus. This practically rules out the open neural tube defect. So one volume tells you everything about the fetal brain in axial section. Moving forward, the same volume, put it into multiplanar plane. Putting a multiplanar plane and put your reference dot at the middle of the palate, with the palate being vertical 90 degree to your imaging. There you have got a complete axial section of the palate, and this is the one which what we call it, we have called it the 3-dot sign. And these 3-dot sign will completely give you a full idea about whether the both side palate which are developed or not. At the moment, the signs which are described they are going to be a maxillary gap sign. If there is one palate which is deficient and you are cutting at a normal palate, you will miss that. So there are things you are going to miss. So to diagnose this, we have called it the 3-dot sign. You can cut in the middle of the palate, and you are going to diagnose this palate defect. A second trimester scan with these are the routine regular things, but what you can do something which is going to be different. Same brain, same action, same evaluation. So just taking one volume, you have got a classic evaluation of the anterior complex, which is fine. You've got the corpus callosum is fine. You've got it right from the tela choroidi, midbrain, and a complete axial section evaluation and the formation of the corpus callosum. Each thing which is going to be visualized so brilliantly, just trying to compare the ultrasound. Here you have to add the VCI, and that volume contrast imaging will add lot of information just like MRI. you probably at a 20-week or 21-week ultrasound will give you far better images, because I heard that MRI can take you not less than 3 millimeter sections. Am I right? Because I'm not an MRI person, so I do not know about the MRI. But sequences, can you get smaller sequences than 3 millimeter in MR? 1 millimeter. So if you can get 1 millimeter, then you will have this imaging. It is actually 1 millimeter images for the axial, and this is a complete mid-sagittal section. Evaluation can be performed much better during this 25-week. You have got a sulcation, gyration, which you can see the operculization, which is taking place nicely. So it's all about adding one volume. If you want to evaluate the brain still in a smaller fraction, you can still go on putting it to 1 millimeter or half a millimeter. Still, you will be able to locate the smallest amount of the smallest cystic structure which you want to evaluate anywhere in the brain. You will be able to diagnose. This is where one of the things which we would like to inform. This is a normal corpus callosum. Look at a normal corpus callosum. Complete absent corpus callosum, no corpus callosum. But look at this. This one is a partial corpus callosum which is developed only this segment, and this is the one which is partially developed corpus callosum. So this will, as you know, that the pericallosal artery, Rui today morning only Rui showed that on the base of the corpus callosum you will run the pericallosal artery. So moving further to that, the pericallosal artery, you know that it is going to give you sunray appearance, and this is a normal anatomy. ACC, you have got a normal as well as abnormal, but how far I can utilize in conjunction with 3D ultrasound. You have got a pathology specimen, normal 3D and normal pericallosal artery, ACC, 3D and sunray appearance. These are the images of the same pathological specimen which we have evaluated. So that's what that's how the correlation is. It's not that some images are something and the pathology specimen is different. It is all same. And this is one where you have got a normal one. This is partial absent corpus callosum. You have got a length of pericallosal artery. Here you have got that typical length of the pericallosal artery. Short and thick dysplastic CEC. You have got an abnormal contour of pericallosal artery. And look at, you can compare it with just normal pericallosal artery absolutely on the left hand side. But look at ACC, which is extremely on the right hand side. The shape of pericallosal artery is going to be very different, and this is going to help you in defining the length of corpus callosum, the extent of corpus callosum, and that's what you can put it across. A third ventricle, one of the difficult structure to identify on ultrasound, on a 2D ultrasound. This is what a 3D can help you. Complete delineation of the entire sequence of your this part of the fetal brain, and you have got exactly that's what you can have on 3D. You can delineate the lining of the entire structure, aqueduct which is there, and you can this is the fourth ventricle you can identify, and that's what on ultrasound you can have this again. One more thing which we find out that how to evaluate the hippocampus. A limbic system and hippocampus also can be identified by using ultrasound or using the volume technology. Now, hippocampus is not a straight structure like this or like this, like a corpus callosum. It's an oblique structure. Okay, it is not coming, it's not going into one direction. So it's going to be like this. If I want to evaluate the mammillary bodies or the complete hippocampus, my evaluation axis has to be in this direction, not straight, not axial, not standard coronal. It has to be oblique. And to get that oblique section, it is the volume. You can rotate your axis and you will have this. Let me show you both of the videos. You will have it. Right now I'm in the middle of, I will pause this. I'm in the middle. You can see the corpus callosum. From that, what I will do is I will just come out. You have got typical shape of hippocampus, and then make a rotation. Just rotate your image to your entire volume, and then you will have a complete evaluation of the mammillary body, including the opposite side mammillary body, which you can see there. So looking at the head at an oblique direction, which is going to give you. So this is one image which is a little bit more brighter. Go right back, go in the middle, look at the vermis, look at the corpus callosum, and then look at the dentate nucleus, and then rotate, and just rotate your image, and this is going to give you a complete kind of, this is the mammillary bodies which is going to be end up, and this is a complete fornix which you are going to utilize, which you can see. So evaluation of limbic system is not possible, and this is the same. You can add on the silhouette mode, and this silhouette mode, if you, the moment you add on, it is going to give you one more idea about how you can really evaluate the limbic system, and that's what, okay, I'm in the right plane. That's what we can evaluate limbic system. A cerebellum. See, why we do ultrasound? We want to replicate the anatomy, what is there inside the fetus, we want to see on the screen, right? So that's the whole purpose. So that's the pathology specimen, and that's the ultrasound. So we can recreate the pathology like autopsy specimen or anatomy right there on the screen, and that's what the power of ultrasound, and you should utilize, and that's what exactly we know, that a normal one, and also the Blake pouch cyst, you will have an elevation. That's what you can always do it. This is a easy thing, so I'm not going to go into the detail. Now, the case about today's morning case and autopsy about normal the anterior complex, and you have got a, as Gustavo told me, this is going to be a very rare pre-optic holoprosencephaly. That's what that's what he said, that on this side it is pre-optic midline holoprosencephaly, and this can be evaluated. In case of absent septum pellucidum, think about it, that you may end up in this. So in ultrasound, you have got an autopsy specimen, and this is what ultrasound, it gives you a 2D ultrasound, but what 3D can give you, this is what a 3D can give you. I will walk through. I've grabbed the volume. I'm just walking through. Okay, so you have got a complete thing. You even you have got the opening of the third ventricle into the third ventricle. So that's a foramen of Monro. You can easily see. You will be able to see that, okay, they are not fused fornices, which is that kind of evaluation. You can do it just by walking through your images. So that's what a case of the thing. Now, easy diagnosis. Borderline ventricular megaly, that was a primary diagnosis I made from that examination. Taking the coronal sweep, I find something which is suspicious here. Okay, so that part of membrane of the septum pellucidum was not developed, and this part was a little, that ventricle was little bit weirdly enlarged. The normal corpus callosum which was seen. And once you can see the normal corpus callosum, normal vermis, which was identified. And then when we took a volume image, help of the volume image, we could see that, okay, we could make out that there are multiple perforations in the septum pellucidum. And these septum pellucidum, eventually, when we try to evaluate further, then we got this PATCH1 mutation, and this patch1 mutation is what is known as holoprosencephaly type 7. Probably our diagnoses are very different. Our thinking process for holoprosencephaly is completely totally different. This is genetic identification of PATCH1 mutation with an absolute normal anatomy of corpus callosum, normal anatomy of brain except ventriculomegaly and septal perforation. So you can have a very variable presentation. This is one very peculiar, interesting case. This was the finding, borderline ventriculomegaly, but this on posterior part of the lateral ventricle was a little bit suspicious. It was showing a kind of like there is a fetal stroke or intraventricular hemorrhage. But this is one, I mean, hemorrhage you can't find in a one small corner, which is that clot is sitting. Usually you will have a more extensive kind of more extended evaluation. Then we started doing the 3D ultrasound, taking all kinds of different kind of, you can see that corpus callosum is fine. One ventricle is bigger. The rest of things I could not find any abnormal in my coronal section. Taking a volume, only was this part which was suspicious, but the borderline, the borders of the lateral ventricles were a little thicker. So when we apply a 3D, it has got a very crystal clear idea that, okay, you are dealing with unilateral ventriculomegaly, which is borderline 10 to 11 millimeter. And then we ask for MRI on the 3D. It was a typical thing. This is the advantage. I've started walking through the image on one plane, and I know you can have the complete kind of other image on the one side. Now I started working on a sagittal image. Now, so correlation from one to another image, sagittal to coronal, coronal to axial. I can switch over by just clicking one switch. And then when we ask for the MRI, it showed that hemorrhage in the right portothalamic groove extended up to the right lateral ventricle. That's all I get an information. And eventually we got the fetal PCR for infection, CGH was normal, but the exome sequencing showed as a moya-moya. Moya-moya disease in the brain, antenatally diagnosed. I think that's what I had a discussion with. So no diagnosis, but that kind of difficult things are rare things you can come up. One more typical, you can see the anterior complex is absolutely abnormal. Again, a case of septal perforation, but these septal perforation, when we got more and more into the diagnosis. Eventually, this is a septal perforation. Again, one more case of septal perforation, and this septal perforation, we had a different cases, different imaging, and the septal perforation ended up in having the diagnosis of trisomy 21. Except perforation, there was no other positive finding. So that's what a variable kind of findings you may have. And this was a Roman cephalosynopsis. So I think everyone has got this Roman cephalosynopsis, but a 3D, what it can give you is just like the autopsy specimen. You have got the pathology, you have got the ultrasound images, volume images, and that's what it can give you. The whole today's session, we are fond of making the thumb rules. You will have in your kit, you will have got a book on the thumb rules. So the simplest of thumb rule, which we have make it for as far as the counseling for neurodevelopmental disorders or a neurodevelopmental delay, 1 out of 2 with severe ventriculomegaly, if they are isolated, 1 out of 3 in ACC, 1 out of 4 in posterior fossa malformation, 1 out of 5 in case of absent septum pellucidum, they will have septoptic dysplasia, and 1 in 10, may have isolated borderline ventriculomegaly. So Aladdin ka Chirag is a good use of TV probe, 2D volume imaging, a high resolution probe, and that's the master key for doing all sorts of neural examination. Thank you very much for patient hearing.
Thank you, sir, for a wonderful talk. Next, I would like to invite S. Suresh for his next talk on brain calcification. Sir need no introduction, as sir is a director at Mediskin System, Chennai, and visiting professor in perinatology as SRMC Chennai and PSG Hospital, Coimbatore, and has a fetal medicine specialist, performed over more than 25,000 diagnostic and therapeutic fetal procedures till date, and over more than 100 publications, including the authoring of books, and he's a pioneer in fetal medicine, fetal ultrasound in India. Thank you, sir. Welcome.
Good evening. Thank you very much for inviting me, and congratulate the coordinators of this course for starting the Fetal Brain Society. And we've come to the fag end of the day, and we need to start looking at very, very small things. And those are intracranial calcification. And when you look back and say, are we going to see them every day? It's not every day, but it is over a period of time, you can have a reasonable number. How much is that? Fetal intracranial calcifications are very rare, 0.4 by 10 out of 10,000 in our own series since 1989. They are seen as bright echo densities. Most do not have acoustic shadowing, and that's very important to see, because whenever we think of calcification ultrasound, we always look for shadowing. In this, we don't have that. And the variety of etiologies which can be present because of that. And there are phenotypic mimics which we need to understand, most often present in the second and third trimesters. We have not seen intracranial calcification in the first trimester as yet. Now, what about the etiology? 4 major headings we can think of. One is infection, which is CMV, toxo, rubella, and Zika virus. Genetic, like Aicardi-Goutieres syndrome, pseudotorch, called 4A1 mutation. And ischemic causes like fetal vascular occlusions and tumors like teratomas, again, extremely rare. You just seen a couple of cases the last 30 to 40 years. Now, what are the types of intracranial calcification that can be present? One is there could be focal punctate parenchymal calcification distributed in the parenchyma, or they could be specifically periventricular calcification, or they could be lenticulostriate. They're also called as thalamostriate, or also called as mineralizing vasculopathy, all mean the same thing. So prenatal infection, obviously the most common cause of intracranial calcifications you see, among them CMV and toxo being the most common. We see random calcification and toxoplasmosis, periventricular calcification in CMV, and rubella, of course, less common, but again, could be random calcification. So here's a case which shows very typical small punctate periventricular calcification. This baby also had microcephaly and also ventriculomegaly. There's a primary at 27 weeks. Head circumference was minus 4 standard deviation. In addition, the baby also had echogenic bowel, placentomegaly, and maternal torch CMV IgM was positive. Amnio-PCR for CMV is positive. It's a straightforward diagnosis of CMV infection. And at termination on autopsy, we confirm it by CMV inclusions in various organs in the fetus. So if you look at CNS findings, CMV findings in the CNS, abnormal ventricles, ventriculomegaly, ventriculitis, intraventricular hemorrhage, abnormal cephalic biometry, cerebral parenchymal abnormalities like calcifications, echogenic vessels of the basal ganglia, destructive lesions of ischemic origin, periventricular lesions involving the germinal matrix. And these are thought to be due to germinal zone tropism of the CMV and also early periventricular calcifications or edema as a result of transependymal resorption of the CSF. But let's go on to case 2. This lady had a fever in early pregnancy. All parameters were less than -2 standard deviation at 33 weeks. So there was a growth restriction. The umbilical artery Doppler was normal, but the MCA showed 1.7 form of peak systolic velocity, showing a significant fetal anemia. So when you see fetal anemia and intracranial calcification, obviously infection is what we think is the cause. So here, maternal torch CMV IgG was high positive, and amnio-PCR done was again was positive for CMV. The baby delivered at 37 weeks, succumbed on day 10. So if you look at the overall risk of CMV positive mother having an affected neonate, the risk of fetal infection is the highest in the 3rd trimester, but the risk of an infected fetus being affected is highest in the 1st trimester. So the transmission rate after primary infection is about 30% during the 1st and 2nd trimester, and about 40 to 70% in the 2nd trimester. Although the transmission rate is high in the 3rd trimester, any long-term problems are very rare. So our concern is early infection and the baby being more affected. So when you look at maternal seroconversion detected before 16 weeks with normal initial scan, what are we supposed to do? We offer amniocentesis for DNA PCR 8 weeks after the seroconversion, but not before 18 weeks. If CMV PCR is negative, we reassure return to normal after antenatal care. If it's positive, then about 25%, which you'll see in about 30%, 25% of CMV PCR positive babies will become affected to some degree. That's why we need to do follow-up scan to see for the development of calcification, which can come later on. It may not be seen early. About 60% will develop sensory neural hearing loss. About 20% will have prenatal or postnatal symptoms, but not long-term issues. About 20% will have long-term problems, including seizures, disabilities, mental and physical function. So here, valcyclovir 2 grams 4 times a day as primary therapy is given. Ultrasound every 2 to 3 weeks to look for signs of fetal infection in MRI at 28 to 32 weeks. Important to know that serial ultrasounds are important because some of the findings can evolve later in the 3rd trimester and not when you diagnose it early in the 2nd trimester. And if the ultrasound continues to be normal, then there are chances that this baby outcome will be satisfactory. Now, what if the maternal seroconversion is diagnosed after 16 weeks with a normal initial scan? You again offer amniocentesis for DNA PCR. Again, PCR negative in about 72%, reassure in about 30% positive, 90% of the babies will remain asymptomatic. And here, again, valcyclovir as primary therapy, ultrasound stimulation every 2 to 3 weeks, and MRI at 28 to 32 weeks in suspected cases. We really do a very good ultrasound as has been shown all along. Maybe you can even skip that. And if they remain normal, the ultrasound remains normal, the risk of neurodisability is very low, but the hearing could still be affected and to counsel the patient on that as far as concerned. So the absence of calcifications is not something. So one of the very important things to know here is when you confirmed a fetal infection with non-severe brain signs or extracerebral signs, like parallel calcifications or isolated ventriculomegaly, or extracerebral signs like echogenic bowel and other conditions, we know that valcyclovir is not very effective. About 40 to 50% will have no long-term problems. 10 to 15% will develop severe brain signs either before or after birth. And about 40 to 45% will have a long-term problems, mainly, of course, hearing loss. Now, I'll give you another case of infection, 26 weeks. Again, periventricular calcification with some spots distributed in other locations. Also, there's placentomegaly and ascites. So naturally, we first tend to think of CMV, but this could also be toxoplasma. So the important thing here is the findings can overlap between these two infections. And we do serology, and if the patient opts for termination of pregnancy, an autopsy and histology will be extremely useful in confirming the diagnosis. Let's go to case 4, which is a patient presented with bilateral ventriculomegaly, head circumference 17 weeks. There was at 20 weeks, head circumference was only 17 weeks early FTR. Dopplers were absolutely normal. And you see in the brain diffuse, distributed focal calcifications and ventriculomegaly. But in addition, the baby had signs of sloping forehead. So microcephaly was there, and there was also arthrogryposis. So here you're having intracranial calcifications plus some additional findings, which are extracerebral findings. So what will be the final diagnosis here? Could it be Zika virus? Because if you go and look at the literature, congenital Zika syndrome with arthrogryposis, there's a retrospective case series study of 6 cases that they had published. Or it could be, it could mimic a varicella syndrome, where you can see it's something like an arthrogryposis, but because of severe muscle atrophy and presence of pterygium, you can contractures, joint contractures here. The limb appears very thin like arthrogryposis. Or could be Pina-Choquet syndrome. Here you can see small brain calcification with typical hands and feet, suspect of Phenerstone, or it's called cerebro-oculofacial syndrome. So again, what has happened is we've identified calcification, we've identified some extracerebral signs, but we have come to a differential diagnosis. Further investigation need to be done. So key messages here, as far as infections is concerned, is presence of intracranial calcifications is a trigger to exclude torch infection. Intracranial calcifications are seen in only 6 to 10% of torch infection. So if you don't see calcifications, it doesn't mean that torch is excluded. Very important. And there's an overlap of phenotype for different types of infection. So let's go to case 5. This lady had a IUD at 24 weeks, reported intracranial calcifications, no autopsy was done. Second pregnancy, again, IUD at 24 weeks and calcifications were there. Patient's brother was having intellectual disability, and maternal uncle's son also had intellectual disability. So there was a family history which is going on here. And when she came to us for this pregnancy, all parameters were in the 5th centile. There was a drop in the growth. The calcification of thalamostriate vessels were seen, and there was also some echogenic bowel was reported. And the placenta essentially looked normal. So naturally, we did a maternal serology workup for torch. It was completely negative. Amnio PCR for CMV toxo was also negative. We had a double confirmation there. And the problem here was a recurrent intracranial calcification, which was looking like torch, like all other previous presentations, but it was not. We don't have any evidence to say it is torch at this point. So such cases, you give a provisional diagnosis of what is called as a pseudo-torch syndrome, or it could be an Aicardi-Gouttier syndrome. So let's see what pseudoTORCH syndrome is all about. It's a rare autosomal recessive disease, intracranial calcification and microcephaly, polymicrogyria, hepatosplenomegaly. TORCH serology is usually negative, and there are three types: PTORCH1, PTORCH2, and PTORCH3. And the gene we look for is called the OCLN gene or the occludin gene. So the importance of index case diagnosis here. This patient who came with the pregnancy, child was born for 14 days, there was seizures, CT brain intracranial calcification was seen. MRI at 10 months showed tachycardia and focal polymicrogyria. At 9 years and 8 months, the baby had microcephaly. Now, this was the first baby's postnatal picture. You can see the CT showing multiple periventricular calcifications and also the abnormal gyration. She comes for pregnancy 2. At 8 months, she reports for with mild ventricular megaly and megacisterna magna. And they didn't do any investigations, but at 31 weeks, they did do a fetal MRI, which again showed dysgyria here. And baby 3.2 kg had seizures from day 2, and baby died on day 11. No investigations were done. So they have one live child which was abnormal. This baby died, and she comes for the third pregnancy. What are we supposed to do? So since we had the index child available, we did a whole exome sequencing in the index child, and then we found that the OCLN gene was positive, homozygous positive here. So father showed it was a carrier state, and the mother showed also a present. And in this pregnancy, we could do a chorion villus sampling to exclude that, and we reassured them that the fetus was normal. So the importance of identifying, and this baby is doing well as we excluded the problem. Now, a very similar appearance is what we have in Aicardi-Goutieres syndrome, which is a clinical mimic of pseudoTORCH, genetically determined. It's supposed to be due to upregulation of the interferon production. It's called as interferonopathy. Large amounts of interferon are produced, and that's because of the defects in the following genes that have been given. And one of the important genes we look for is called the TREX1 gene, which is there. So this was also reported from Hyderabad, where they, in addition, suggested that they had 2 cases in which they could see that in addition, there was also fetal cardiomyopathy. And they went on to suggest that there is no documented prenatal phenotype for Aicardi-Goutieres syndrome. Diagnosis of AGS confirmed that the right phenotypic clues of intracranial calcification along with cardiomyopathy, because they had for both the cases, they had cardiomyopathy. They suggested this could be added. And so that brings us to case 6, where she had 2 unexplained intrauterine demise with both of them growth restricted. And the third baby also had a neonatal death. And they had done echogenic kidneys and hepatomegaly. They had done a chromosomal microarray, and it was reported as normal. So 3 babies, no diagnosis so far. And she comes for 4th pregnancy for early onset growth restriction with hepatic calcification alone, and small specks of intracranial calcification. Amniocentesis is done, so we went on to do a whole exome sequencing instead of a CMA. And this was, of course, you can see those small specks of calcification there. And what was the finding we got was positive for the TREX1 gene. And that was the diagnosis of Aicardi-Goutieres syndrome was proved. So case 7 is also again ventriculomegaly, referred as ventriculomegaly, but a very unusual type of ventriculomegaly, but there were small specks of intracranial calcification. So obviously when we did that more detailed analysis, it was a scission-cephaly, probably a closed-lip scission-cephaly here. And it's a neuronal migration disorder with, and there you see in COL4A1 mutation associated with scission-cephaly and intracranial calcification. So, and there's of course cortical dysgenesis, also pontocerebellar hypoplasia. So in our own experience from 1989, out of 685,000 cases, 31 intracranial calcification. That's how rare it is. And associated abnormalities were seen in 17, isolated in 14. And if you look at the isolated anomalies, the most common is musculoskeletal. When the brain is affected, the muscular system is obviously affected, and that's probably the reason for so much. growth abnormalities in C also seen in a significant number. So what about the outcomes? We got outcomes in about 61% of them. About 16 of the 19 patients decided for termination of pregnancy based on IC calcifications alone. And the two which are alive are still abnormal. They're still having sequelae and one neonatal death there. So in summary, finding of intracranial calcification is a trigger for further testing. Associated findings must be elicited. Overlap of phenotypes between etiologies there. Infection screen, store DNA always, and that's absolutely essential that whenever, because the entire phenotype cannot be obtained in the antenatal period. You would need to wait and do the appropriate testing. Doing just a CMA is not going to help, or doing blindly a whole exome sequence is not going to help. You need to be very specific about what you are looking for. And perinatal autopsy and histopathology in cases of termination of pregnancy or perinatal demise, and recurrent IC calcification, consider genetic causes. And I'd like you to welcome you to Chennai for the 18th cusp in September 26, 27, 28, 29. Please block your dates. And also I invite you to join sonaacademy.com every Wednesday morning, 9 to 10. It's a clinical meeting where you can present your cases. It's open to all. We have done 522 meetings till now. About 250 people join every Wednesday. So thank you very much for a patient listening, and have a good day.
Thank you, sir, for this great talk. Next, we have Dr. Ashok Khurana, sir, Chairman and Consultant in Reproductive Ultrasound at the Ultrasound Lab, New Delhi. He is a past president of the Society of Fetal Medicine, former ISWAG ambassador in India, and former dean at ICMU. He's a mentor emeritus, Society of Fetal Medicine, and editor-in-chief at Journal of Fetal Medicine. Sir will be speaking on new tools in fetal CNS evaluation.
Try this. A very good evening to all of you, and I guess by the time we get my talk organized, we can do a little simple exercise to make sure that all that wonderful cardiac output lying in your pelvis goes back to your brain. So maybe you can all rise and then sit down again so that you won't be in snooze mode. I have an interesting topic. It sort of summarizes all that you've seen this morning. And if I'm on there, let me just make sure this comes on. Sometimes it misbehaves in Ahmedabad. A little terrified of organized places. And let me see what we have here. So far, so good. Yeah, it works. Wonderful. So congratulations, Prashant, for this fabulous meeting that you organized here in Gujarat. The first foundation meeting of the Fetal Brain Society. And it's really been an exciting day for all of us. We've seen the most fabulous images. We've also realized that we moved way beyond these completely stupid images made by Leonardo da Vinci, which was imagination. Obviously, he had no clue what he was talking about. And then artists went on to do things like that. But today what we do is nice, wonderful images like this, which tell us that yes, Leonardo da Vinci was correct only up to 14 weeks of gestation. And beyond that, we have a lot of ultrasound, which now tells us what to do. We have 2D, 3D, 4D color and everything else. But what I'm going to talk about is the new ultrasound tools for fetal CNS evaluation. You've seen the images today. So let's see the tools, but not a historical description of what's been happening over the past 40 years. It's going to be what these tools can do today, where they've evolved up to, and how we can best handle them. And we know that there's been a huge evolution of imaging technology in genetics, and these have been game changers really in fetal diagnosis and prognosis. And this talk provides a window into this very exciting and useful space. You've seen images like this morning of when you shift from a transabdominal to transvaginal, you get images like this. And you saw some images from Prashant like this, which show you how you can use all our conventional tools. But I will take you through some of the new transducer technology, some of the advances in diagnosis, the new windows for 2D, 3D, 4D, and Doppler. guiding the geneticist, therefore, with a detailed phenotype, because that is where the secret lies. You heard Professor Gustavo Malinger also tell us that you will have a return of 20,000 possibilities, and it makes no sense because we already knew there were 21,000 possibilities. We were trying to narrow them down. And therefore, we have to get that. We do use artificial intelligence for this, and I will refer to that. I'm not going to show you an atlas or a show-off showcase. It's just doable stuff for everyday problems, because we do realize that we need a plan for the future, and we also need a plan for today. And so we have to reinvent ourselves by making sure that you don't get left behind thinking you can't catch up. No, we're going to catch up, but we're going to change with the way the tools change. We're going to accept this change and then move forward. Because what do we really need in India today? We have all these people, and they have all these diseases that keep us busy all the time. We have to make sure that, most importantly, when the patient comes to me for the first time, the point of first care, I'm going to be able to give enough diagnostic and prognostic information from that ultrasound scan to make sure that they have the most sensible further bit of workup. The country that I wish to see, of course, is very fancy machines like the one you see here on the screen. And this is exactly what has happened in India. The first few machines sold in places like Riva, which you and me have not heard of. The second one went to Barwani, and the third one went to Giridih. These are populations that are this much compared to even the housing society that you all live in, which is this much. And yet they serve that purpose. They guide us correctly because they're being used correctly, and we're making sure that every patient gets the diagnosis. And this is how we conserve our resources. It's not that the machine is expensive. Every iPhone is expensive when it comes in, and 1.5 years down the line, everybody's affording it, and you give your old one to your home staff. This is exactly what we should be doing with our machines. You wait a little while, you buy it after 1.5 years, and make sure you use it correctly. And so I will take you through some of the learning resources that are easy to access. And of course, I'll stick to ultrasound and MRI and genetics. You've been hearing a lot already, and you will hear also in the next 3 days. Oh yes, before we go any further, I take lots of money from lots of companies to do lots of good work, but that's not spent on my personal self. I just make sure it's spent on teaching so that all of us can move forward. So you will constantly hear so-and-so give me lots of money, which is all absolutely true. The things I'm going to talk about is this, that until day before yesterday, this is how we were looking at a nuchal translucency if we didn't add on the black to make sure that the black looks black and the white looks white. What we do today is make sure that the black looks black, the white looks white, and the gray looks gray. And this is possible because we've had all kinds of course, fancy names to these things like lyric architecture, like augment and stuff. But really, what's going to be the outcome of this stuff? What's going to be the outcome of this stuff is that I can now see brain parenchyma, so that instead of making my nuchal translucency black like this so that it suits the certification by the Fetal Medicine Foundation, I actually have an image which facilitates my measurements to be correct, but I'm able to also draw upon the wisdom of articles like this that came many, many years ago. And this was from Lachman in 2012-13, where he told us that, look, you can start suspecting that the corpus callosum is not developing correctly by a simple measurement in the midline in the same section as you measure the nuchal translucency. Because we were wiping all this stuff out completely, we were missing out on gray information. Now I can draw these two lines from the back of the sphenoid to the top of the midbrain to the outside of the skull on the skin, and make a ratio. And the midbrain diameter to the Fox diameter ratio is well above the 95th centile in over 86% of the cases. This is the stuff you and me need to do on an everyday basis so that it can work. We also realize that the transvaginal transducer doesn't always work, and you and me have to work a little harder on a transabdominal scan, either because of a persistently unfavorable position or fibroids. And we know that lots of mothers are getting pregnant late, and in India, we have a proliferation of fibroids, and they're always sitting all there right in the cervicouterine isthmus. And of course, a nice, thick, complete placenta previa, in which case you can never push that baby's head down. Now what do? I need to work on that transabdominally, and with the kind of stuff I now have, I can get the resolution, I can get the penetration, I can get the outlines. As long as the fetus is facing anteriorly, I can work on the anterior stuff. And then when I work towards the back and work my way to the back, I can get the posterior cranial fossa as well. So this is how we are able to work with all of this, even on a transabdominal scan. There are some commercial names for this. There is the Radiant technology, which gives everything more like a 3D appearance, which aids in very crucial border differentiation. There is Ultra, which gives me more axial and lateral resolution and pushes me more towards an MRI-like image. And of course, the 1 millimeter stuff we discussed during the day. And then, and most importantly, I have a function which I call Augment, which makes sure that I get a nice, clean, robust image, even on my average patient that I see in the great city of New Delhi. And we will come back to this in a while, but just see how beautifully you can actually see this cerebellum, and you can see the outlines, how beautifully you can actually see the sylvian fissure and talk about it without even the need for making all those wonderful measurements. You heard Karina say this morning that, look, I want to be able to see it on the basis of the image alone, and here it is. Because this, now don't laugh, this is the obesity map of India. And I am here, where we have a very high obesity incidence of abdominal obesity. So we've made this statistic. It's not my imagination. It's not a joke. This is from a national survey on the incidence of obesity in this great country. Therefore, I'm going to have to work very hard if I'm in these northern states, which is where I am, or where Dr. Suresh works in these parts of the world. Chandan is very lucky. He has all those wonderful thin patients. That's why he has the prettiest pictures ever. But the rest of us have to make do with almost a lot of obesity, and therefore we have to work on it. So with that, I have to produce images where I cannot say, look, I can't see the near field even if I tilt my probe 45 degrees. You heard that tip this morning. I have to see the near field. I have to see what's going wrong and why the middle of this brain doesn't look right at some points and looks not so bad at some points. These ventricles are not correct. I'm not sure about the cerebellum. And then I realized that when I do get my mid-sag, there is something that's gone terribly wrong with this brain. There's a lot of this that you would end up missing, and by just calling it ventriculomegaly and then waiting 6 weeks for results. You and me can't afford that. We need to give an answer, and we've got to make sure that if the prognosis is bad, we've got to do it. And this is now pretty much possible because you have this wonderful neuroimaging platform called Lyric, and you have the resolution at depth. And this is what you need to do. And therefore, we no longer have our high BMI patients as a challenge anymore because we're able to do this. Now, we've heard of guidelines this morning, so I won't go through those, except to say that, yes, we must follow guidelines, but importantly also to realize that ultrasound done in the proper way remains the mainstay, and we have to get as much information out of this. And yes, MRI is very good. MRI is excellent for the radiologist because you do nothing and make a lot of money. And you don't even have to think. But we have to produce the right kind of images, and we have guidelines from ISWAG. Except when we look at those guidelines and we try and follow that on a detailed basis, most times we manage this. Many times we manage the SAG and the oblique SAG. We rarely are able to see a good idea of what is happening in these planes, which are my coronal planes. And that is now overcome fairly easily. And so let's talk about this that I was showing, that I've seen a nice clean cerebellum, but when I measure that cerebellum, I realize that, look, that cerebellum is not right. It's 17 weeks, 5 days, and this fetus is 20 weeks plus. I then say, okay, what do I do next? And, you know, you could follow those little books like we used to use before. Dario Palladini's book is now going to have its next edition, and, you know, it'll be available from next month, or we could use Berer Benasrov's book, or these texts, or move on to some of these wonderful things, some with AI, some without. Phenotype is my favorite. But what I use on a daily basis is Mala cards, and this is what they do for us. They give you a small list, which is a workable list, And then you have these and you say, okay, you have these genes. And then you make sure that your geneticist is covering this. We know the genetics has changed so much in the last 1 year that microarray has to go out of the window and that anything that is based on gene sequencing has to come in. The Germans haven't been completely stupid for using only exome sequencing all these years. They have made sure that their exome sequence is different from what you and me get to see. What you and me get to see is a bunch selected by a bunch of idiots who are veterinary geneticists and have decided what they have to look for, because there weren't any other geneticists available in this country. So they all came from Dairy Research Institute, Karnal, and they flooded the country. What we have done is to make sure that each one of these geneticists now has the correct pipeline, the correct database, and therefore will include everything that you could possibly not have picked up if you were missing out on that microarray. You're using gene sequencing to get a more accurate result, and therefore you're using an exome sequencing that is catered to give you the result. And then you say, look, this is what I'm looking for. Are you covering these genes or are you not covering these genes? Otherwise, the story you and me land up with is this. First pregnancy, October 2017. Images are pretty nice, actually. There's a small transverse diameter of the cerebellum and agenesis of the corpus callosum, bilateral club feet and a partially clenched fist with a pointing finger. There's a narrow flared thorax, as you see here. No choroid plexus cyst or renal anomaly. There's no evidence of cytomegalovirus, no growth restriction. And of course, she drops the pregnancy and the microarray is normal. She comes right back, and this time she says, look, there's something seriously wrong here. And doctor, you told me exactly this last time. And I pull out my notes and I say, yes, it's the same thing. And you know, it's happening in my family, and some more cousins got married and they got it too. So we called in all the cousins and we figured, okay, what is happening? This is one of the great business communities of this country, the Agarwals. And we sat and we worked out what could possibly be wrong. And we worked on the pontocerebellar hyperplasias, and we said, okay, this is the COAC gene which we need to work on. So the COAC gene is now included in the exome sequencing that we do for CNS defects in our part of the world. So that is how you come about it. But where did the story really start? The story started that, look, I won't depend on images like this. I'd rather do images like this, where I will work hard enough, get these outlines, make sure I'm picking up choroid plexi all the way back, making sure I'm picking up this as a plague spout. But I'm seeing this, which is a nuchal that is still showing me bubbles, and that shouldn't be there. Therefore, I need to look at all of this again. I will call her back, and then I'm not going to wait till 23 weeks and 6 days to call her back, and then sit and work on this. And how do I do it? By pressing those odd buttons on my touch screen that say, look, this is how you can get a nice, clean image with without any effort, and all you're doing is investing a little more money into this. So when we add this high BMI mode called augment, and we add on a bit of radiant, you immediately start picking up structures. And then when you rebuild your scans, like this one in the mid-sag, that's the bit of nuchal edema. And you realize that this posterior cranial fossa is not the kind that Dario Palladini showed us this afternoon. And then you say, okay, now I will do my handling of this, and then I will do. We realize that, yes, it involves a lot of transducers, but every transducer is not expensive. What you and me need to do is to make sure that we reuse some of our transducers, because transducers have a longer life than the machine. And therefore, we will now handle that accordingly. We also realize that we can facilitate our workflow with the help of presets, which are one touch, and that you can program these. So the presets that I use in my part of the country with this fantastic abdominal obesity that we handle on a daily basis is completely different. And then we have a small p, which is the little pediatric one where we use for our 40-kilo patients. And then we have the big P, which is our big Punjabi ones, which are about 82 kilos when they first get pregnant and 104 kilos at 20 weeks. But we manage images like this for them with a single preset that is done by you and me. We know that automation also helps us to push through this easily, and it's a single button. We do a single acquisition in the BPD plane, switch on one button, and the measurements do come out automatically which is really useful in the hugely overburdened environment that you and me live in. We've also made a reasonable amount of progress on color Doppler, and images like this where we were getting pretty lost and saying, oh, do I pick it up? Do I not pick it up? Are no longer the images we use. What we're able to do is to do a whole lot of better stuff and say, okay, my color is going to be right. I'm going to get this as a preset, and I'm not going to label this as a vein of Galen aneurysm. No, this has feeders that are coming in from the dural sinuses, and therefore this is a dural sinus malformation. And as you know, this made it to the cover of the White Journal last year. When we get technology like this, it's also a lot easier to then get a global view of vascularity. And here you see another not so dramatic dural sinus malformation, but you do see that the circle of Willis is a little more full, that these veins are much bigger than you normally expect them to be. And we weren't so sure when we were looking on the 2D and color, but the 3D reconstruction, which again is a single button, works pretty well. And this is a 35-weeker that is giving me this image. Not the most exact thing to do, not the easiest thing to do, but most importantly, when you look at this, this is a transabdominal image. We know that transvaginal is not the easiest thing to achieve at term. This is a transabdominal image, and this is what technology is doing. I have a couple of minutes more, so I will re-emphasize that in the first trimester, we now have this more intelligent way of looking at, of course, the posterior cranial fossa. You heard Roy describe this morning, and we look for the choroid plexus in the fourth ventricle and the normal communication. But most importantly, this set of images, which are coronal images, and how do we achieve those? We go through the same exercise, and when you go through the same exercise, instead of depending on what we used to do before, you do a single sweep, and then you do, because you got such high resolution, you do a TY, turn them around so that you can see those coronal images, and you don't have to struggle with that anymore. So when you see images like this, as Chandra showed you in his talk, they're not really the most difficult. They happen pretty automatically, and you don't have to make an effort. Because of this, I also get to see things like this, which is, okay, I don't see my aqueductus sylvius like so. I see a big hole. And then when I reconstruct here, I see that there's a huge abnormality going on at the back of the brain. And I see a molar tooth in this 13-weeker. A nice, simple, straightforward molar tooth at 13 weeks. Enough time for me to investigate my Joubert, enough time to call in the relatives, and enough time to give everybody an answer. We know the windows exist. We have to start using them. We have a huge anterior fontanelle that we can go through. Most of the sutures are not fused at this time. And therefore, even if it's simple cysts that you could mistake for conatal cysts, make sure that you do use all this newer stuff to make sure that you have a proper anatomical definition for further guidance. One or two more images to show you how I use a lot more TUI to differentiate between, for instance, this is straightforward. This is Indian Kefli. This is straightforward. This is the usual holoprosencephaly. What about this? Is this a semilobar holoprosencephaly? Is it ventriculomegaly? Observation A, the choroid plexi are differently oriented, not along the long axis of the cranium, but vertical. Also, as I go through, they are uncleaved at this point. Therefore, this is a holoprosencephaly and not a simple, straightforward ventriculomegaly. And exactly the same thing in this situation. Typically, when I used to see these big, large ventricles, I would say, of course, ventriculomegaly, lots of ventriculomegaly, drop the fetus, all done. No, there is this little fusion across the midline that tells me that, look, there is much more than meets the eye. Investigate this further and get the answers. And this is how we're even discovering things like the middle variant of HPE far more frequently than we were looking at it earlier. And the more you see on 3D, you know, the more you will end up seeing on 2D. And then you're therefore doing a lot more work transabdominally without having to make sure that you do a 3D on everyone. The last plot I want to show you is how we've revolutionized genetics even before 9 weeks of gestation, especially in our infertile population. So This is the umbilical cord. So obviously this is not the head end. Obviously then therefore this is acrania. Obviously therefore I will send the products not for my 1921 A, B, C, D, E, F, G, but for a 750K microarray, or better still for an exome. You know, both of them cost the same in our part of the world now. And therefore I will get an answer. And I therefore make sure that I look for morphology even when I'm looking for a miscarriage. Of course, there are normal variations like this one, where I know that a globular rhombencephalon is a normal variant at 10 weeks and earlier, and that also at about 10 weeks, the aqueductus sylvius can often be far larger and globular and yet not be abnormal, and therefore we will not label it as abnormal. This does involve a lot of expertise, a bit of cost of equipment. There's an embryological timetable, blah, 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 blah. But the fact is, most of the time, you're doing it for the benefit of the patient. What we need to do is this. We have to make sure that practicing obstetricians should be aware of what is available and use this technological progress. The greater the use, the lesser the cost. Imaging specialists should rapidly adopt state-of-the-art technology to facilitate diagnosis and prognosis, particularly at the point of first care. And geneticists should demand detailed phenotypes to facilitate optimal testing. And thank you so much for your attention.
One last minute. Can I have, can we have Dr. Gustavo? Dr. Gustavo. Morning also, who were there at 8 o'clock, we started the session at 8 o'clock. We wish that tomorrow morning, sharp at 8 o'clock, we will start the session, right? So we will honor those who are coming at the right time. And one more announcement. Please, you may not click the pictures during while lecturing. Pay attention. We will give you a recording available online for 1 month. Okay, so don't click pictures, just be attentive what they are teaching. That is more important, and that's exactly the one reason we are going to do that. 1 month, we will keep all the lectures online. Yeah, please. Yeah, yeah.